Hello, this is Dr. Shannon Flummer-Felt for Great Lean Leaders, making the business case. And we're just thrilled to have today with us Dr. Margaret Diamond, and she's the president of U of M Health Regional Centers, and she runs several hospitals for this entity. So welcome, Margaret. It's great to have you.
Thank you very much. I'm so pleased to be here.
Wonderful. Can you tell us a little bit about your current position in the title? What all does that mean? And how long have you been in the position? I know you've had a very prolific career. Your resume is just so impressive. So tell us a little bit about where you are now and how did you get interested in this career and position?
Okay, well, I'll start with where I am now. I'm currently the regional president of the University of Michigan Health Network. And really what that means is the University of Michigan is an academic medical center, as you know. They found the need to branch out to cover more lives and expand into Michigan. So the University of Michigan and Sparrow Health System entered into an affiliation agreement in April of 2023. I joined the organization in May of 2023 and moved into this current role in August of 2023. So all fairly new, but putting all the pieces together and joining obviously the best healthcare system in Michigan due to if you look at the ratings and top 20 in the United States. So quality and lean processes are a daily occurrence for us with the team.
Very good. That's very exciting. And, certainly for those listeners who may not know, the U of M healthcare system is truly just a world-class, noteworthy operation. So it's great to know that a lean leader is leading the charge there for them. So can you tell us, back up a little bit more, tell us a little more about yourself, just a brief biography and maybe some of the highlights of your career and accomplishments. What have you experienced? And just helping us to understand what's important to you, what drives you, what makes you tick.
Sure. Well, I went to undergrad school back in the day when really for women, the three major career tracks were nursing, social work, or education. So I took the easy route, although I admired nursing and teaching, but I thought social work would be far more passion-oriented and goal-oriented for me. So started out with a bachelor's in social work, got a master's in social work from Boston College, and that was really what I looked at in terms of the field placements were medical. So really got into how the social aspects and determinants of care really impact both the patients and the providers. So then went on to get another master's from the University of Michigan in healthcare administration, an MPA there, and really looked at not only as a social worker helping people, but really how I could help processes. So at the same time, I was working at Henry Ford Health System, which is a really well-regarded health system in the Detroit area. And they actually brought in Dr. Deming himself, and Dr. Deming and his team really taught us PDCA, process improvement, eliminating waste. And this was back in the early 90s. So I was fortunate to be very young in my career to begin to learn how to look at things in terms of a process and in the mistakes in healthcare. Obviously not people-oriented, but flawed process-oriented. And then shortly thereafter, Dr. Berwick came out with the Institute of Health to really look at the airplane industry and how they really had standardized things to reduce crashes and reduce anomalies in the flight patterns and so on. And really, how did that overlay into healthcare? So really got into that with my master's in public administration. At the same time, we were learning about Toyota and their lean journey, and some of the Deming aspects that they put together, but then also some of the Japanese aspects which were emerging lean. So I really feel like in the first third of my career, if you could chop your career up into threes. It really, I was just so fortunate and probably one of the few to get not only the Deming piece of where process improvement started, but also, you know, in the automotive industry and then transfer it to healthcare, but also then the lean leadership piece in the whole Toyota example.
Yeah, I mean, what an honor to have actually had a chance to work with Deming back then. And I remember I had a chance to see him at a conference speak, and it would have been in the late 90s, and I think he was about in his 90s by then. So boy, he must have been even seasoned and had things really well thought out by the time you had a chance to work with him. That's great.
He actually was in his 90s, but he worked a 12-hour day while he was with us at Henry Ford Health System. He was an amazing scholar.
Wow, that is just that's incredible. But you're right. What a great combination you had. So, as a woman being able to step into this and have these very unique experiences, which now I think are just would be so highly regarded as well. What a great start for you. So, can you tell us a little bit more then about the U of M health system and what its lean journey is like? I know you mentioned that you use it prolifically, and can you give us an idea of how did U of M start working, the healthcare system start working on this, and what works for you well and maybe not so well, just kind of overall give us a picture of what goes on there with the use of lean.
Well, the University of Michigan is an academic medical center and university. I mean, they've been engaged in lean. If you look at their quality, if you look at their mortality, things like wrong site surgery, they are number one in all those aspects in terms of 5-star care. So the Sparrow system is really lucky to have joined the University of Michigan. So just the nuance though of Sparrow and University of Michigan coming together, you're marrying an academic medical center who's had decades of lean management and quality improvement, as well as adherence to the highest compliance standards, to a community hospital that really was a tertiary level 1 trauma in downtown Lansing and mid-Michigan, and then accumulated 4 smaller community hospitals. So trying to get all those entities on one platform has been not only a lean journey, but also change management. So I would say to you that it's my career is unique in that there are specific skills for change management, and then there are also skills for invoking lean, but they're complementary of each other. Because really what you want to do is get away from the person and the, what I would call kind of the informal culture and get more towards the unbiased, looking at data, looking at metrics, and really performing and outperforming based on those metrics and the stretch goals you create.
That's interesting. And that transition from, more of a personality driven, type of culture into a data driven decision making methodology, that can be very hard, and also hard for leaders, because a lot of times, we see leaders, they lead by inspiration and, what clicks for them and makes them drive or makes them excited, as opposed to really looking at the data and understanding the context of really how to create value. So that's very interesting. That's really a good explanation, Margaret. So if we think about now a little bit more about your growth pathway, were there any, you mentioned a few of the key things, with Deming and Toyota, and having a chance to combine your interest in people and understanding that relationship to process. But is there anything that sticks out to you that was, really foundational for you in terms of getting to where you are as a lean leader? Was there, sometimes in your journey, if you look at the roadmap, you might turn right, you might turn left, you might go straight. And, have there been any points in your career, in your life, that have been like that for you, that, you made a decision and it ended up just really helping you to get to where you are today?
Yes, there are some pivotal people that I can count on one hand that really shaped my life and my career. I really was not, looking back, I was not an A student in high school. I think I enjoyed more of the social aspects of high school than the academic aspects. So kind of was collared by my French teacher, who basically said, "You have a lot more to give than what you're giving." So really inspired me to go to college. And then as I moved on in my career, I had very strong female leaders impact me. When I was director of social work, the vice president that I reported to at that time was an African American female, and she said to me, "It's nice that that you think that you're a social work leader, but you're underestimating your future if you stay just in that box." And so I really didn't know what she meant, and she pushed me to the point where it was a little bit uncomfortable at the time, because she was sending me to, that's when lean really started in the Deming. She appointed me as sort of, one of the process champions. And this was back in my 20s. And I'm thinking, wow, this is a left turn from what I thought my career would be. I mean, my goal of my career was to get to a point to be to be invited to Mass General to be the social work director. So this was completely not on my radar, but that's where I started to learn. And if she had not pushed me, I don't think that I would be where I am in healthcare right now, because I think we as women, men seek out mentors, and there's probably more mentors there because, women in leadership, especially in healthcare, other than nursing, has been a recent phenomenon in the last 20 years. But I think that the women that have shaped my career are trailblazers, and I was lucky enough to have them, really impact my life. Another was the MSU provost, who became president when I worked at Michigan State. And we actually looked at the dysfunctional aspects of the faculty practices and employed lean practices there and lean principles. And really that we had a 30% lift in faculty productivity, and that there was no squawking about it. It's just that we took out waste and inefficiencies, and it was running the best it had run in 20 years. So, but I wouldn't have done that had I not been pushed again by Dr. Simon, who was the provost at the time.
Oh, that's really great. And, also, I think people say that opportunities really just don't fall out of the sky. You have to be open to those and prepared for those things. And so, when people enter your lives, like these three noteworthy people were so influential, you obviously also had an openness to that, and, were eager to listen. And, there's probably a longing there for some kind of mentoring, which like you say, maybe comes more naturally for men sometimes in leadership and, with the way they socialize and so on. So that's very interesting. And to hear about the work that you did at MSU is incredible. I know there's still some, there's some lean projects going on at MSU as well. So that's very exciting to hear about that. As a fellow faculty member, I'd be thrilled to have my productivity increased by 30% as well. So be good to hear about that sometime. So what point then, with the mentoring that you had, at what point then did you actually say, this lean leadership or this lean stuff seems to work, and if I'm going to be a leader, I want to apply it to my practice? What were the circumstances, or what were the challenges there that you were looking to address, or things that you were trying to accomplish at that point? Where did that actual leadership journey in lean begin?
So I have to say it wasn't a one aha moment. It was a process, and it was an immersion, if you will, because Henry Ford Health System at the time, when I was a young leader, and then I was promoted to several times within that institution before I went to Michigan State. They were in a financial crisis, and they really realized that they needed to become more efficient. So it was more of a cultural transformation for the entire organization. So it's sort of like I was swept along. I wasn't sort of sticking my head out in a crowd. I was part of the crowd that needed to understand that we needed to move nimbly and swiftly towards financial solvency, while at the same time improve our quality to be the best that we could, and strive for that best in class for lowest mortality, highest outcomes, lowest infections, the clinical pieces that you would say, if you look at other industries, automotive has its, top of class, but those were our clinical top of class. So we used the tools that, Deming gave us, and then moved on to really having the A3s and the scorecards and the metrics, and really looked at kind of the key events. Like, you need to look at process rather than people. You need to have a guided approach with regular intervals of touch base on the metrics. Those, again, that leads to data-driven decisions rather than hunches or assumptions. And then really capitalizing on the efficiencies and waste. And, if you've got a patient that has come 30 times in the last 6 months to the emergency room, we're failing that patient. There's something wrong. There's something wrong in the process that we didn't get, that they continue to come back.
Yeah, that's really interesting. And I loved your definition of, not only becoming more productive, more efficient, and optimizing resources, but also the quality of the experience. So many times we hear about, okay, we're going to focus on operational efficiency, and what that translates to is we're going to lay people off,
Right.
or we're not really looking for the value proposition. And so that whole idea of stepping into the shoes of the patient and experiencing or thinking about what they're experiencing, and then building that delivery, that healthcare delivery around that is very, very exciting. And I think much appreciated, I'm sure, by all the people who have come in contact with you and the patients you've served.
Well, I think too, I mean, this Henry Ford was a little bit ahead of its time, because it needed change, just for the financial solvency and building blocks for the future. But if you look at the guideposts of insurance changes, Medicare and the commercial insurances now really, they hold out what we call risk-based payments based on patient experience. All health systems that are under Medicare and Medicaid need to have some sort of mechanism or third party monitoring their patient experience. And so the better the patient experience, the better the payment for us, as well as value-based payments. So, the more sepsis cases you have, or some of the trends where it's not, you're not hitting the quality guidelines, the less you're paid. So I think that drives the whole piece as well. So if we move, again, as we evolve in healthcare to using more value-based payment in terms of incentives for getting it right the first time, and not having the anomalies, I think you'll see the population health piece of healthcare continue to improve.
Oh, that's very, very exciting to think about that, and what that might mean, for sure. So you've mentioned a couple of times, Margaret, about how the importance of people, and making sure that process is separated from people, in terms of when you're looking at where the improvement work is going to focus, and so on. Are there particular lean leadership philosophies that resonate the most with you, that you would follow, and people who work for you would say, yeah, Margaret really goes for this one in particular? Is there a bevy of them, or anything in particular that sticks out to you and has been helpful?
So I'll approach this question from a leadership standpoint, because I think I can talk as a person involved in lean, but I want to look at it from my current assignment as a leader. So part of it is training, right? So people just don't understand. I mean, if they don't have continuing education in lean leadership or lean processes, they can read books, but certainly if it's not promoted in the culture that you work in, then it's sort of like a second language that you don't use. Then it's going to be something that you struggle with or that you forget about. It's not a one and done. It's part of really putting that as a central theme in the culture of the organization that you lead. So that's really important to me. And then taking my subordinates and the staff all the way down to supervisors and looking at giving them, to an extent, larger or more, half day, to a week, to even a year-long kind of immersion into how do you develop yourself into that leader who uses the principles of lean. And then what's the culture that you're adding? What can I do to help your local culture in your department or in the areas that you lead? How do we all add value? And then, we're never going to be perfect, but can we strive for the least amount of errors and variances and processes that we can do?
Great.
And
That's
I'll give you one experience that
sure.
is very recent. We had a department that was, if you compared this department, and it was around how our patient experience performed. And we just didn't have the right setup for the department. This is in the job that I currently have. So rather than tweak it or make excuses, which was sort of going on at the time, we said, we've got to completely change the culture. So we actually blew the department up and we're starting from the ground level. And people said, well, that's, you're going to waste 8 to 10 months because you're building back the department. And my retort to that is, it's going to take 8 to 10 months to make sure that we have the right structure, function, and process to meet our patient needs for 8 to 10 years. So sometimes you got to take a risk to say, this is so broken that we need to break it apart and build from the foundation with the lean principles.
Yeah, I think that's great. To actually have the opportunity to what we call like white sheet it, where you start with a blank piece of paper and rebuild it. And then, you think about blue sky or, the blue ocean, how big is it? What could it what's possibly out there? What's possibly within our organization that we could do? Those are just great exercises. And isn't it interesting how institutionalized dysfunction becomes, where it is actually a risk to get rid of dysfunction, and you would think it wouldn't be that big of a risk, but it truly is. And so it does take some courage for sure, and I appreciate that very much. That's great to hear about, and just really being focused, like you say, on the patient experience and value to them. So, and along with the training also, which I love, and Toyota, I'm sure has a very specific training methodology, learning by doing,
Yep.
and they make sure the qualifications are there, and that is by job embedded learning, not by going off and getting a degree somewhere necessarily. It might be, but they want to see if you can do it or not, and let you be coached through the process. So that's very exciting that you're willing to invest in people like that. So we mentioned a couple tools here, but are there any tools in particular that you like to use to solve problems, address crises that might come up and eliminate waste and so on? Is there an example of one that really sticks out to you that is like, this just really, made such a difference? And that's the exciting thing about lean, I think, is when people actually go through and use some of the tools, and it actually does make a difference. It's not just reading a textbook, as you said. It's something that can make a true impact and change results and make things better for all stakeholders. So do you have an example or two, some tools you can talk about and share with us?
Yep, I sure can. I think the whole Gemba walking around to look and really talking to every week, our leadership team walks into patient rooms and we walk the halls to say to the medical assistants, to the certified nurse assistants, to the nurses, to the housekeepers, what's going well, what needs to be improved, what are some processes that are that we need to look at, and what materials or other things do you need to do your job. We have found out so much just by looking at the folks that are closest to the processes. And I just want to say that the larger the institution, the harder change is sometimes, because you get mired in these layers of autocratic kind of, well, I'm not going to do that because that's not my department. And, that person's going to get mad at me because I said, whatever process was wrong. So trying, number one, to eliminate that from the culture, but number two, being out there as leaders, showing the staff it is not, we want you to speak up. We want to get from a process problem to a near miss. Like if I just had near misses to celebrate, I would be the best healthcare administrator ever, because we don't want errors. We don't want those things to happen. So number one, getting input by walking around, or the Gemba walk, and then really looking at the A3s. We use A3s a lot, both in our quality and our risk departments, and our operational improvement area. So how do we, for instance, the patient experience, what were we doing right and what were we doing wrong? Well, most of it wasn't right. So let's start from the beginning and put those processes and work with the stakeholders to say, what is the ideal process? And then how do we build it and how do we measure it?
Mhm. That's great. That's great. The idea of Gemba is, it is so simple.
Yes.
And yet, like you say, it is so effective. One time there was a theory that was going around before we kind of had Gemba formalized like we do now. It was called management by walking around. And it seemed like, well, that seems kind of like almost too easy. But the idea that you really do try to understand what that means. And also I was thinking, it must be very nice for your employees to have the leadership team, the executive team, come and listen to them and talk to them about their inputs and their views on improvement. That must help in terms of employee morale and engagement in problem solving when they're heard.
Yeah, I think, and that's again how leading change and leading lean are complementary to each other, because when you come into an organization that needs to change, and I mean, for instance, they're losing enough money that they need to, affiliate, like the Sparrow system, affiliate with the University of Michigan. People often view that as, oh my gosh, I was with an organization that failed, right? Well, no, it's not a failure. It is a transition to a larger platform in which the organization can grow. But with that, you have to look at sort of giving up some of the traditions and the culture of the past and embracing the culture of the future. And that's why I really am such a disciple of lean, because again, it doesn't cast blame. It creates stretch goals. So each one of my leaders has KPIs that they must meet on an annual basis. And it has nothing to do with personality. It has nothing to do with, what color hair they have or what suits they wear. It's achieving those goals that are plainly laid out at the beginning of the year, that we measure every quarter, and more often than that. And then if they're off their goals on a quarter, then we do a deep dive in terms of why are they off? Is there something that did we have flawed data to begin with? Do they have the adequate resources to be able to achieve it, and those types of things?
That's very exciting. And you mentioned these KPIs and goals. And I wanted to ask you about where do those come from in the context of how do you conduct strategic planning and management, and something we call Hoshin Kanri,
Yes, yep.
where you use the true north, mission, vision, culture, goals, all of that of the organization to help understand the future. And how do your strategic planning and management cycles work? You mentioned every year, every quarter. Are they renewed that way? What does that bigger picture look like for those KPIs and where they come from?
So again, just joining a major health system, the University of Michigan really creates the master goals, and then we take those goals in terms of how do we implement them within the organization. So they have cultural goals, and one is base plus growth. And the base means belonging, access, safety, and experience, patient experience, and then the employer, the caregiver experience. And then the growth is how do we eliminate waste? How do we look at growth in terms of the number of lives that we're covering, the longer our patients live, and grow. It sounds kind of like an oxymoron, but growth means less variables to the care process. So more
Very good.
standardization.
Yeah, no, that's really interesting. So how are your on your base plus growth? That is always like strategically important
Yes.
and to work
Yep.
off of that is what you're saying. Very
Right. There are annual goals that are placed towards the base plus growth. So for instance, in base, it's, this is just for 1 year, but where are we with, diversity and inclusion? And how do we change our hiring practices or our retention practices? Access, how do we get more primary care providers if we can't provide a new patient appointment within the next week? So those are just examples of annual goals that we would put in base plus growth. And then in the interim, for Sparrow, we have kind of 3 buckets of recovery. The first bucket is financial. So how do we get from $170 million loss to break even within a year, which is quite a daunting goal, right? But we're on track thanks to lean and other things. But it's a financial piece. So financial solvency, because you need solvency to be able to create capital to keep things up, like equipment and buildings and deferred maintenance and so on. And then so you've got financial, and then clinical. What clinical areas do we need to grow? And what areas do we need to look at in terms of, do we really need this clinical area, or is this something that we need to make or buy? And then third is cultural. And how do we get that movement into what I would call everyone's rowing on the same lean and quality boat? Because the true north is zero harm, zero defects, and zero variation from our processes.
Wow, that's fantastic. Talk about Six Sigma. You guys are there, the highest levels. So, you had mentioned that you took the risk with taking the time for restructuring your office. What do you say to people who say, well, an A3 takes a lot of time? Where's the worth and the value in it?
I mean, to me, everything takes time. Demolition takes more than construction when you look at healthcare. So you need it's not taking time, it's participating in an investment. So, and the other piece is it's human behavior. You're getting everyone on the same page, because as you well know, if you look at change management structures, 60% of all change management, and again, going from lean and impressing on, quality and what I just described as base, that's a change in people's comfort level. So there is always going to be resistance. So the A3s create a platform to get everybody on the same page centered towards the same goal.
Are you fairly, excuse me, I just started coughing here a minute, but are you fairly systematized in terms of how you use A3s? And then once you go through the continuous improvement loop, because you mentioned this already, the standardization and how important it is and what you learned from the automotive companies about standardization. Can you give us a context for that in terms of getting to that leader standard work and what that might look like for you in the work that you do?
Sure. So I've actually created, I now have a position, it's called Chief of Staff, but he came from a General Electric where he was trained in lean and in the non-clinical areas, which is good. And he leads our entire process improvement in lean enterprise. As a matter of fact, it's called Enterprise Improvement Management office. And so those project managers work with our operational managers, not only to create an opportunity for the A3s and the lean process to begin, but also to mentor the operational departments through. So there's a partnership and an educational piece at the beginning. And then we create the end goal, and how do we engage that team on the steps in order to create the end goal? And I'll give you an example. We were looking at, we just couldn't figure out why we were losing so much, like our gross to net revenues in our flagship hospital in Lansing. And so we brought in some external nursing colleagues, and they said, well, you need to focus on, length of stay, and you need to focus on your admitted patients versus observation patients. While the hospital was focusing all their process improvement on length of stay. No one was looking at the ratio of observation patients to admitted patients. So this group came in and they did a deep dive. They said, give us 50 random patients that are in your hospital. So we gave them the names and the diagnoses, and these nurses went out and looked. And so we were putting all our eggs in the process improvement of the length of stay. They came back and they said, you're looking at the wrong thing. Your resources are on the wrong thing. You need to start doing process improvement and process change on the observation piece. They basically said, you have people who are on day 5 or 6 who are in the ICU who have line drips and life-threatening illnesses, and no one has switched the status of the patient from observation to admission. So we didn't even know that. So now that we know, we've had a rapid cycle improvement team in the last 3 months, and our switch from observation to admitted, and we should have known that as a level 1 trauma center that we would get sick patients, right? But we actually are now on par at the 50th percentile of the acuity of a similar hospital our size. But so we were sort of giving money away before we did that.
Yeah.
But again, we had to go through that objective lean process and say, where's the fragmentation? Where do we need standardization? How are we going to measure this? And let's go. And literally it's been 90 days and we've really flipped probably an additional, I would say close to 18% admissions that would have gone as observations.
Wow, that is fantastic in such a short time period too. So yeah, that's very interesting that Gemba actually results in standardization, because in contrast to other organizations who may not have lean leaders or be familiar with lean, typically the model for standardization is, you put out a memo and you tell some, this is how we're going to do it from now on, or maybe even you do training and people still don't really understand why or the context of it. And it's very hard to standardize when you try to deliver, changes that way. But the Gemba based, starting there and moving towards leader standard work is very, very compelling. So thank you for sharing that example with us, Margaret. Well, is there anything else you'd like to add We'll get back into another round of interviewing you on
Sure.
some of these leadership practices, but is there anything that I didn't ask you about or you're thinking about that would be important for you to add at this time to what you've
Well,
already shared with us?
I think one postscript is we, at least in the healthcare industry, and I think maybe in other industries, it's the American culture, and I have, a teenage son, so I see this in my family life, but it's microwave. We want an instant solution to a very complex problem. So rather than kind of tearing apart the hairball or the process that is, tangled, we do things the quick way. We hire a consultant who comes in, the definition of consultant is you live 50 miles away and you can give a recipe, which oftentimes doesn't work. So my advice to myself and my advice to others in terms of really looking at how do you create sustainable process improvement in lean is that you can't rely on someone else to come in and do it for you. You've got to get the people that are closest to the process, and sometimes listening to your own folks in terms of how the organization has failed them is painful. But it's worth the pain to go through to say, okay, this is a compelling story of why we need to change it.
Mm-hmm. I think that's wonderful because, one of the things that we're trying to get at here is making the business case for lean. And so, a lot of times people think I need something quick. I can't wait around. I can't do this PDCA. It seems like, 3 extra stages of work I have to go through. And I think what's important about that is that if you do something too quick and you aren't using PDCA thinking, I mean, you mentioned the rapid development, rapid deployment work you did. It's called, Kaikuku round of
Yep.
work, go quickly. You can go through lean quickly, but you're still having the discipline of plan, do, check, adjust, and that, the A3 continuous improvement cycle. And the idea there is just like you say, it just doesn't get you where you want to go when you aren't willing to make that investment of time and effort.
Right. And I'll give you one last example before we close. I was asked to come and turn around a hospital in Oakland County, Michigan, and their OR, they had 3 previous consultants in the OR, and basically the chairman of the board said, well, Margaret, I don't know how you're going to fix this because it's just a failure. We have long lead times. The surgeons have gone to other hospitals because we're so inefficient. So I actually, and the person that your colleague of the person that we brought in, who is affiliated with the Lean Leadership Program in Oakland University. And he said, yep, we're going to fix it, but it's going to take a year. And so, of course, the board chair said, well, what do you mean a year? This should just take a month. Again, let's get this fixed now. So we engaged, and it took a year. But I will tell you that was back in 2018, and that OR is still the leading OR in terms of efficiency, turnover, infection rates being almost 0 because of the cleanliness and so on, sterilization of any OR in Oakland County. So again, yep, it takes investment in the front end, but boy, your benefits that you reap long after, the work is initially done is amazing.
I think that's just such a great story about making the business case for lean leadership. And I think it also shows that, that you as a leader, sometimes you do have to, coach your board and others who are pressuring you to make a decision in a certain way. And to understand that, look, if we do it right, and it's a big deal to be the best OR in Oakland County. I mean, that is a very wealthy district. They have a lot of county. I mean, they have a lot of wonderful hospitals available to people. So that's a major accomplishment, what you've just described. And I think it just makes the case here that we're trying to make about why should we take the time to become a lean leader? What about being a great lean leader? So
Right.
So, yeah, so thank you for sharing with us today, Margaret. Really appreciate it. And I'll look forward to seeing you for your round 2 interview.
Great. Thank you so much.
Dr. Margaret Diamond, everyone.
Was that okay, Shannon?